relapsed samples, and we found a similar finding, which is that the broad kinase inhibitors, listartinib, could inhibit both fairly consistently, whereas the narrow index inhibitors didn't do a very good job at inhibiting diagnostic leukemia, whereas they did a much better job, statistically better job, at inhibiting relapsed leukemia. So this has influenced our thinking about how to strategize giving these inhibitors maybe in some kind of sequence. And with that in mind, we designed a study where we're using an inhibitor that's a narrow index inhibitor to try to prevent relapse after they've already obtained a remission by some other mechanism. And this is a study that I presented some interval results on, and I'll walk through it here briefly. But it was a study where we took patients who were going to receive an allogeneic transplant who had FLT3-ITD leukemia. They had to be in a remission by classic 5% or less criteria. They had to meet criteria for transplant, have a donor, and be ready to be transplanted. And they could receive sorafenib as a way to maintain remission prior to transplant. We then transplanted them, and we would start the sorafenib after engraftment, 500 neutrophils or 30,000 platelets. And then we targeted the dose based on how well they tolerated it. The key here was that we didn't give the full dose to the patients. We gave half the maximally tolerated dose, 200 milligrams twice a day, and then we adjusted it if the patients were tolerating it. And we would adjust it in one of two ways, either up or down, and many of our patients, I'll show on the next slide, actually had to go down to lower doses. Tolerance was reasonably good. We had 18 of the 42 patients who did receive it as pre-transplant therapy. We had no episodes of graft failure. We had one patient who had a secondary graft failure after a CMV reactivation and a tough time getting the CMV under control. We didn't see any veno-occlusive disease of the liver, which was a concern when we started this study, as sorafenib can influence liver enzymes. We were able to start the drug around 60 days post-transplant. We saw a number of typical side effects from sorafenib, as one would expect. Graft-versus-host disease flared in about 20% of the patients at the time of requiring a dose interruption or reduction. Ultimately, the rates of graft-versus-host disease, though, in the sorafenib patients, in our opinion, were not different from those other patients who are not receiving sorafenib at our institution. And the last point here, I think, is one that's a take-home message, is that the dose of the sorafenib in many of the patients was only able to be given at this half dose or even less in many of the patients, and despite that, we thought we were getting adequate dosing of the drug. The kinetics of looking at how much drug was in the system is very interesting with sorafenib and many of these kinase inhibitors, is that they're very broad trough levels. So some patients have 10 micromolar or microgram per milliliter concentration. Some have double that. And the amount of inhibition was indistinguishable for the most part across these dosing levels. So we're getting good inhibition even at these lower doses. And this is the results we were reporting compared to our historical data. So 2 years out, about 75% maintaining remissions on sorafenib, whereas we were probably about 50% in historic data in complete remission 1 transplants. So the conclusions that I have come to so far in this field are that we are now able to individualize therapy based on molecular genetics. FLT3 is the first one that I think is now shown that we can confer a survival benefit by incorporating a novel targeted agent. In my opinion, regardless of the amount of FLT3 that's in the the leukemia, there are associated with inferior outcomes versus those patients who don't have FLT3 mutations. As I mentioned, FLT3 treatment outcomes can be improved with incorporation of these targeted agents. And 7 and 3 plus midostaurin improves overall survival in both FLT3 ITD patients and TKD mutation patients. The choice of the inhibitor is gone, but influenced by the disease status. I think there's more work to come there, whether we're going to be using midostaurin versus one of the small, narrower drugs to maintain remissions is yet to be proven. There has to be more data gathered there. But I think that we're going to learn that over time. And then lastly, drugs like sorafenib can safely, can safely be given or incorporated into transplant paradigms, which was a big concern at the onset. And patient-specific dosing is an important part of all these drugs. It's not a one-size-fits-all drug. None of them are. If the patients are really sick, they're probably on too much, so lower the dose is my take-home message. Happy to answer any questions.
¿Tienen alguna pregunta? Por favor.
Dr. Prats, what is your opinion about autologous transplant? In this year, Dr. Goran published in March, autologous transplant is the best option in patients without donors. What is your opinion and the combination with the new drugs that you are talking about this?
That's a great question. I think our interest in autologous transplant is more favorable over the past few years than it was maybe 10 years ago. There have been a few studies, one of which you mentioned, showing a benefit to patients getting one in remission. I think that the important part of those studies, the recent studies, has been the improvement of our ability to detect minimal residual disease. I'm of the opinion that if you don't clear the residual disease, taking someone to an auto transplant is not likely to be successful. Many of those early auto transplant studies were confounded by people who went into it with MRD, and as such there was no finding of benefit. But now that we're able to detect MRD better, I do think that there is a role for some of these patients to perhaps get an autologous transplant and then perhaps use an inhibitor to maintain a remission afterwards.
Esta pregunta es para el Dr. Prats. Hello, Dr. Prats. I have a question regarding the best methodology that you can use to read the MRD. It can be a mix of flow cytometry, PCR, or any new generation sequencing?
It's a very timely question. There are a number of ways you can check MRD. You mentioned flow, genetics, cytogenetics even. I am going to present a poster at ASH this year looking at the FLT3 group of patients, specifically answering this question, which is that no matter how you found MRD, whether it was flow-based, cytogenetic-based, or genetic-based, it conferred a poor outcome. There are some things that could be done to improve that, and one of which was using some of these kinase inhibitors to lower the rates of MRD. As you know, the FLT3 test, though, is not a very good MRD test. It can only pick up about 5 to 10% of mutated leukemia in most situations. So I wouldn't use that, but I think if flow can pick things up, it can be useful. My only caution of flow-based MRD is that it's very difficult to do consistently, and I think particularly when you're talking about less than 1%